A pleasure to be back helping you with your webinar series. My name's Chris Atai. I'm the VP of Product Strategy for SHP, and with me is Zeb Clayton, VP of Client Services, and so we're pleased to be able to present both data and some insights on the hospice quality reporting data and trends. For the objectives today, what we first wanted to do is just really set the stage. HQRP has really been evolving over these last couple of years, so we're going to go back a little bit in time and just kind of give you a little bit of sense of some of the changes that have occurred in kind of getting to the quality reporting that we see today, and then we'll talk about some of the trends and benchmarks that we've seen with both the Hospice Item Set and CAHPS Hospice. We've been collecting data since the beginnings of both of those, and so we'd like to show you what we're seeing with some of the data in that way. And then finally, we're going to talk a little bit about what's next. You know, what's the direction quality reporting is likely to take. So I think we've got a couple of insights there to kind of share and give you that perspective. So let's get going. Setting the stage. You know, when CMS first provided some information in 2017, the final rule about CAHPS, you know, we learned about what they were intending, right? They wanted to use this hospice experience tool to make it publicly available. But what I noticed, what was interesting, is they said that they were only going to be reporting, at least once they got going, on an 8-quarter rolling average. Now that's different than what we have seen in the other CAHPS reporting. And it's likely to do with the fact that there's not as many surveys generally in the hospices that are going to be reporting. So that was one of the things that we learned that was different and new. They also announced last year that the 11 quality measures that was originally part of the CAHPS hospice survey was simplified and consolidated. So they actually eliminated 3 of the measures and taking some of those questions and putting them into the other quality measures that ended up with then 6 composites and 2 global. Now, we can see some of the data. For the first time, they started sharing it, I think it was probably last December, where you could actually see the data for the National CAHPS Hospice. And I've got a link here that you can identify through data.gov of what some of that data looked like. And this was, I guess, CAHPS scores from April 1st of 2015 through March 31st of 2016. I don't believe that's been updated at this point.
Yeah, so it's only a year and a half old at this point.
That's right. So one of the other things we learned in the final rule for 2017 related to the Hospice Item Set. One of the things that they said they were going to do is remove what had originally been a 7-day length of service requirement. They were going to include now all hospice patients in that. They also changed the treatment preferences and beliefs and values so that you could not ask that question any earlier than 7 days prior to admission. So that was something that we learned, and that was new. And of course, the big ones that we learned about was their new composited measure at admission, as well as the new measure pair set. And that was going to come from getting data from our new HIS 2.0 that went live as of April of this year. And they've continued to say that they're going to look at new data collection considerations, and I'll talk a little bit more about that when we get to the final section of this. But Zeb and I did want to look at a little bit of the data regarding that length of stay requirement. By eliminating it, what did that mean in terms of the scores that we would see? So in the light color blue, you see the length of stay when they are greater than or equal to the 7 days, versus the dark blue, which is for all lengths of service or stay. And so this is for periods for the last 12 months. And what you see is there wasn't that significant of a change between them and, excluding the first 7 days versus including all. So I can imagine, and I think CMS said this, you know, there's about 25% of the patients who have lengths of stay less than 7. So they wanted to make sure they captured all of this good quality HIS data for all patients. CMS has done a pretty good job of providing updates around HQRP. They actually had a on-site program back in January of this year I think it was in Baltimore, and they kind of went through a lot of the data and information that you'll see in some of these slides here. And at that time, they said, well, we're going to be coming out with Hospice Compare in the late summer of 2017, and in fact they did, but with one exception. They weren't able to give us the CAHPS hospice data, and right now that's scheduled for the winter of 2018. The two new HIS-based measures, which is again data that they're collecting from the HIS 2.0, they also made it clear at that time that it wouldn't be incorporated right away, and that makes sense. They need to have time to collect the data before they publicly report. I guess it's likely that we'll probably see something at the beginning of 2019, once they've had a full year of data collected and a chance to analyze what the data looks like. The final bullet here, though, I think, which we've seen in a couple of other references, is the fact that they are planning to come up with a star rating between 1 and 5 stars at some time in the future. And I think that's going to be important for hospices to evaluate, again, where they stand relative to their scores and their outcomes, because it's going to be used in a way that will kind of help differentiate hospices based on that star rating. Also in January, they talked about what the Hospice Compare would look like, and they said it was going to follow the inpatient rehab facility and long-term care hospital sites, and in fact it did. They look a lot the same. But we still don't know. What will they do with CAHPS? Will that be a second tab? Will they, by chance, be able to provide state scores in that way? They didn't with HIS, and my guess is they're likely not to be able to do that for CAHPS too. But you know, the likelihood is that there will be a 6 months delay, maybe even a 9-month delay, but we're not sure on the CAHPS yet since we haven't seen it. There are similarities to Home Health Compare, a couple bullets that I've noted here, and you know, we're kind of tracking to see how close that they come to that. But at least the fact that home care has been through it gives us an idea of what to expect in that reporting. So I just wanted to share a picture of what it looks like, and you know, this is again similar to some of the other tools that they've used. A pretty easy interface, a way for you to be able to reach and kind of list out the hospices that you're interested in. I like the picture. I think that's kind of friendly in that way. And if you were to open up and look at some of the scores, you'll see that they've identified the HIS scores in 2 different groupings: patient preferences, as well as managing pain and treating symptoms. I just used an example here looking at 3 of the hospices in a market near me, and you can see they have the national average, but no state averages, unlike what we see when we look at some of the home care data points.
It's nice to know too that they actually went to 0.1% here. When we looked at the CAHPS scores, that they just did a full percent, which with these scores, some of them being so high, it's, you know, rounding up or rounding down, you don't get a real accurate representation of your score. So it's nice right off the bat they did a very precise, accurate score here.
Yeah, that is nice. And so one of the things that CMS is promoting is to kind of keep an eye on what the refresh dates would be. And at the bottom, I've listed the URL for the reporting here so that you can see when is the Hospice Compare going to be refreshed. So the next one is actually scheduled for November 21st, and then you can see the quarters after that when they'd be reporting, as well as which quarters are part of those patients that were reflected in the Compare. They do make a point, though, to let you know when they will be making the data available in CASPR, the 30-day period that you can then you know, submit for potential changes if that's the case, as well as the freeze dates that they will kind of share in that original update that's in the preview report. So helpful information there to be able to take a look at. Zeb, I wanted to point out this is kind of maybe old news for some, but you know, there were differences when they first came out with the HIS measure that's being used today, and I did a little update in a blog, and I shared some of the differences here. But in the treatment preferences, I think, as we noted earlier, the length of service of at least 7 days went away. So between the left-hand side and the right-hand side, when they made the changes, they made it clear what they were going to be looking at, as well as the no earlier than 7 days prior to admission. So if you want to see what this looks like for all the measures, we do have a URL down at the bottom where you can actually get to a crosswalk that we put together for all the 7 measures.
And one thing just to note is that all of the changes except for the 7-day length of stay requirement, all the other changes were very, very minor in their effect on the scores.
Yeah, that's right. So finally, just kind of bringing you through where we are today, we do have now a new HIS 2.0 with new data elements that we're collecting at admission. So you can see that they've added patient zip code, payer, and some skip logic. I note that with zip code, there's some interesting things that we might be able to hear later in terms of what Medicare is thinking about in terms of how to look at scores relative, where maybe some of the social economic patients may be living in terms of zip codes. That's one of the areas that we've thought about, as well as the issues relating to dual eligible or Medicaid and other payers in that way. And then finally, the bigger change, this is where we're collecting a lot of data now on the discharge assessment, is the 14 new data collection elements that show both levels of care as well as the number of visits. And there's a lot of detail that's in these visits that I think are going to be helpful for both the new measure to the new measure pair that they have, as well as some other analytics that we're going to be able to do. And Zeb, I know you have some data that you're going to share with us soon on that new measure pair, but why don't you start off and kind of talk a little bit about some of the trends that you've been seeing over the last couple of years.
Sure thing. And I get the fun part of the webinar. Chris gets to talk about all the regulatory stuff, and I actually get to share the data, so I owe him one on this.
Next time we're trading.
So taking a look at this, we have, as we look at these scores, just to give you a little bit of an idea of where the data is coming from, everywhere that we're going to be presenting data here, it's coming from our national database. So we got about 1,300 hospice locations that are contributing to those scores. So what you'll find is the benchmarks that we're presenting as data starts coming out on Hospice Compare, it's typically going to be pretty close when you're looking at it at a national level. The scores in the SHP benchmark tend to be a little higher than whatever's published nationally, because everyone in that benchmark are hospices that are participating, obviously using a program to improve quality. So you tend to see a little bit of an uplift in the scores there. But everything you see here, we can expect to see when you look at Hospice Compare. You'll see similarities there in the national numbers. But what we're able to do with our scores is we're actually able to give you more detailed breakdowns, like quarter-over-quarter scores, and slicing and dicing the data in different ways that you don't necessarily get on Hospice Compare, which is always really interesting. So we're going to start with taking a look at CAHPS Hospice, and then we'll go over and look at some of the HIS-based HQRP measures as well. Now, what we see here on this slide that's really kind of interesting is in looking at those 8 domains that are publicly reported for hospice, when you look quarter over quarter, what we did for these is we show, obviously we did a distribution, green being your higher scores, red being your lower scores, and showed basically from quarter to quarter what happened with those scores. And when you look across there at the very beginning of the CAHPS Hospice program, or even the first year, most of your highest scores were in that first year, which means that scores have come down somewhat in that second year. Now, if you look in detail at these numbers, what you will also find, very little variation. We'll keep that in mind when we look at HIS scores, because that is not the case when it comes to the HQRP measures for HIS-based measures. But your CAHPS scores are not going to be very volatile. you're going to have, maybe a 1 or 2% swing in your score over time. That's, there's a good and a bad there, because you're not likely to see your patient or your caregiver satisfaction scores be all over the map, but they're also a challenge to move. It takes work to get those scores to go up, but if you can get them to go up, you're usually going to be doing better than the benchmark, because the benchmark is going to be pretty stable. So this will give you a good reference to see with each one of these domains what has happened over time. And if you want, you can compare those to the national numbers that are published. Even though that data is, a year and a half old, it still gives you a comparison for what's out there and what's going to be posted when your numbers for CAHPS Hospice go public.
So it's interesting. This is quarter data, so this isn't year to date or 1 year or 2 years worth. But look at quarter 3 of 2016. So for each of the domains that you just mentioned, that almost was the period that had the worst across each of the questions there. I wonder why. I know we don't have that answer, but that was interesting to see in that way.
Yeah, it definitely. And as you look across there, you'll see that even those fluctuations, I don't think any of them was more than a 1% change.
Sure.
But yeah, and we will see sometimes quarter-to-quarter fluctuations, which is, of course, explains why CMS is averaging those results out over a 2-year period. Taking a look at our next slide, what we did here, this is actually showing a measure that is not a CAHPS Hospice publicly reported measure, but it's something we do in our reporting because we feel that it brings an additional view or an overall score to your numbers. What this is essentially we take the overall rating, we take all of your CAHPS Hospice domain scores and we roll them up into a single score. So we say essentially, what was your single score overall rating? It's not a star rating, it's nothing like that, but it is a single indicator of quality. And as you can see, as you look across here, that score is pretty consistent from quarter to quarter. You don't see a whole lot of change there. And the same goes there for just comparing the recommend hospice there. Pretty stable over time, very little variation. But it is interesting to see that as an overall indicator of quality, around 84% is the score that you get there when you roll everything up there.
Yeah, so this is a graphic that just shows you how flat it really is, right? Because sometimes when on the earlier slide you looked at numbers, it was kind of hard to, how much is that changing? Well, this really shows how flat it is. I do want to make the point, though, that for overall rating, our 90th percentile of all of our clients actually came in at about 92%. So you can do it. There are hospices out there that have some pretty good scores. So keep that in mind.
Now, one thing that we thought would be interesting to look at would be not just the quarter-to-quarter scores for that 2-year period, but also going into some of these domains and looking at some of the lowest scoring questions. Because there are, I guess you would call them problem questions in these domains. And as you look down here, you can see some of them even have scores in the mid-60s, which is pretty low when you look at the overall CAHPS Hospice score. So, with this, why is this interesting? Well, if you are working on improving a particular domain or composite on your CAHPS Hospice scores, you might be doing great on several of the questions. It might be one question that's really dragging your score down. So instead of focusing on 4 or 5 questions, you can pick one question and make that your focus and really see where you have opportunity to improve. Now, in looking at this, just to kind of run down them, under the hospice team communication domain, it was family kept informed about when the hospice team would arrive. You can see that's right around 70 to 71%. across the board for every quarter. 2 questions under getting timely care had really low scores. It was help provided during evenings, weekends, or holidays, and requested help was provided when needed. You can see how those 2 questions could relate and could both have a poor score if someone wasn't able to get the person they needed maybe in off hours. Getting help for symptoms, the 2 questions were help provided for trouble with constipation and help provided for feelings of anxiety or sadness, with feelings of anxiety or sadness being down, below 65% there for about half the quarters. So you can see that's one. If you have a low score for getting help for symptoms, which is one of the lower scoring domains, those 2 questions can be a real focus. Training, as you can see, is a real challenge. That domain, scores in around 72%. So that is one where most hospices are having a challenge with getting the score up in that training domain. In there are 4 questions that have lower scores. Pain medication side effects were discussed. Training provided about pain medicine side effects. You can see how those 2 would be related. Training provided about how to help with trouble breathing, and training provided about patient restlessness or agitation. So if you can focus on that training composite and get that score up, that's a real opportunity to differentiate yourself in your CAHPS hospice scores.
And you can also see that these are also pretty flat. There hasn't been a lot of changes, a lot of improvements. But boy, going back to my grammar school days, 60s. Those were D's in my grading. I didn't get many, but there were D's. So something they need to really work on.
All right, so let's take a look at our key drivers, and we wanted to show this. This is an interesting look at for a particular question. When we talk about a key driver, what we're saying is if we look at one question on the survey, we then want to compare and say, what are the questions that had the highest correlation to influencing that question? So when you scored well on the number you would use to rate the hospice care, which other questions also scored well in those instances? Which ones had the biggest impact on the highest correlation to a good score on that question? So we can kind of go down here and we'll see. As you would imagine, if you're going to rate that hospice a 9 or a 10, you would probably also recommend that. That makes perfect sense that those 2 questions would correlate. But what we did that was interesting here is we took a look over and said, for these, 3 of these questions are ones that were found on that last slide that we looked at with the lowest scoring questions on the CAHPS hospice composite, the ones that make up the composites. So if you can increase your score, and this is 3 different composites. The first one, requested help was provided when needed, was under timely care. There, 27 is under help for symptoms, and 23 is under training. If you can improve those 3, you can kind of get a double whammy. You can improve those 3 domains, but you could also improve your universal question there, the number you would use to rate hospice care, which obviously, was one everyone wants to improve. And by extension, you're very likely going to improve your would recommend question as well, because it's highly correlated.
And anything that's over 50%, so on the right-hand side, it's actually colored green, and I think we even go and show you what the reds are, but those are highly correlated. So that's those are pretty important to kind of track. They're considered strong, I think, over 50%.
Absolutely. So really interesting to see that. And there's other correlations that are interesting, but we wanted to highlight those since they're, they tie into what we were just discussing. Now we're going to change our focus a little bit. We're looking at first CAHPS hospice scores. Now we're going to move over and take a look at HIS scores. And what's really interesting with these is we have a lot of data. We have twice as much data as we have for CAHPS hospice because HIS has been around longer. We go back to July of 2004 with our start of the program, and we you know, it was very timely here with this webinar because we go all the way out to 3 full years of data to look at. Now, some of our other slides were even going to go through September because we had an additional quarter there, but we wanted to compare full year periods here from the start to the current and show what we saw here year over year. Now, what we did, because there have been some refinements and changes in the methodology over time, we applied the same calculation across all 3 of these years, so we get an apples-to-apples comparison in how the scores have changed over time. Now, some of these aren't that dramatic. If you look at dyspnea screening, they improved every single year, but it was by less than 1% overall of change, from 98.2 to 99.1. That kind of is the type of thing that we saw in the CAHPS hospice scores. Now, if you go to the other extreme, take a look at pain assessment with the 4th measure there. You see, when we started in that first year, it was by far the lowest scoring HQRP measure at 71.6%. Now, when we look at the last year, July 16, we put 04 and 05. Those should be 14 and 15.
Yeah, good point.
So we'll give ourselves a little hand slap on there. We'll replace those zeros with ones. We look in July 16 to June 17, we're at 91%. That was a dramatic change, 20% in 2 years. We rarely ever see that big of a leap in a measure calculation. And so clearly providers have been looking at that measure, making it a focus of their performance improvement programs, and really seeing results, which is great, you know, if that's something you struggle with. It also is a very powerful reminder that if you want to differentiate yourself with your scores when they hit Hospice Compare, you can't just rest on your laurels. You constantly have to be improving because everybody else is working very hard to improve as well. So it's those trends, we see every single measure improving each of those 3 years. Now, what we did just to demonstrate this, we showed the CMS benchmark here for 10/2015 to 9/2016. So basically a year ago, 2 years ago to a year ago, which is the most recently available data. Then we showed in the middle bar the SHP score for that same period, and then next to that the SHP score for the next year. So that takes us all the way through September of 2017. As you can see here, as we mentioned earlier, the SHP scores for that same period, the 2 bars to the right, the gray and medium blue, the SHP benchmark tends to score some amount higher than the CMS benchmark. And you see that demonstrated there with pain assessment being the biggest difference there. Now, if you look at the next period, the dark blue bar, you see every single measure improved from year to year, just like we were looking at previously. So the scores have continued to improve, and they will top out at some point. You get into the high 90s, and things will flatten out. But some of these measures, are still have some, like pain assessment. It's 92. It's still your lowest scoring measure. It's got 8% to grow to improve there. So we will see things continue to improve. Now, what's interesting with that as well is as you start trying to do star ratings, where and most of your measures are in the 90s or high 90s even, it's difficult to do a distribution that has any meaning there. So it'll be interesting to see what they end up doing with that and how they can make a meaningful star rating that doesn't put people with scores in the mid-90s at a very low star rating. To just demonstrate and kind of nail home that improvement over time, here is the HIS composite process measure. Now, there's nothing public on this yet. This is a brand new measure. It's not one of the ones that you'll find on Hospice Compare yet. It will be up there once they've got sufficient data to report it. However, since that measure is calculated based on measures that were already in place from the start of HIS, we're able to calculate that composite process measure all the way back to as far back as we want to go. As you can see, we see a steady improvement there from all the way down at 65.2%. And if just to take a step back, if you're not familiar with the composite process measure, it's essentially saying the percentage of patients that met every measure that they were eligible for. So if a patient was eligible for 4 HQRP measures and all 4 were met, then they had this composite measure met. If they were eligible for 4 and only 3 of them were met, they didn't meet the composite measure. So as you can see, it has steadily improved every single quarter from Q3 2014 up to Q3 2017. So to score well or to rank well in that measure, we're already at 93%. So you've got to have a pretty high score. So it just shows you it's competitive out there, and constant attention to these measures is really important. Now, the other thing that we want to take a look at, and this is where we get into some piping hot data. This is about as fresh as it gets, because we've only got data from HIS 2.0 for this measure, because it didn't even exist before. So you're not going to see anything on Hospice Compare for this for quite some time. But we've got 2 full quarters worth of data to look at, and so it's interesting to start seeing what this data shows. And you know, obviously we can't trend anything over time yet, because that would be a pretty boring trend, but we can start to see what the benchmark is showing. Now, these 2 new measures, this here is just to demonstrate what those measures are. The first is the hospice visits when death is imminent, or at least 1 visit in the last 3 days of life. The plain text description of this measure is basically the percentage of hospice patients receiving at least 1 visit from registered nurses, physicians, nurse practitioners, or physician assistants in the last 3 days of life. And that's based on those new fields that Chris showed on the HIS 2.0 assessment. The other new measure is hospice visits when death is imminent, at least 2 visits in the last 7 days of life. That's the percentage of patients receiving at least 2 visits from medical social workers, chaplains, or spiritual counselors, LPNs, or hospice aides in the last 7 days of life. So that gives us the definition of these. Now let's take a look at what the data shows on these measures. So we pulled this from our national benchmark. As you can see at the bottom, just to reiterate, this is April 2017 to September 2017. So for the visits in the last 3 days measure, 87.6% of patients had that measure met. So that's at least 1 visit from RN, MD, MP, and PA. Now, what's interesting is to look at what the patients that didn't have that measure met and see what the reason was. And what is really fascinating with this is 7.5% of that 12.5% that didn't have the measure met, well over half of them had a visit done, but not for the disciplines that are eligible for that measure. So that just kind of helps to demonstrate if it's a measure maybe that you're struggling in, it's interesting to look at if you have reporting that shows you why that measure was not met. About 5% of patients had no visits done in that last 3 days.
Actually, 87.6 was higher than I was expecting. So I'm happy to hear and see that that data.
Yeah, and just as we saw with the other measures, we're very likely to see that score trend upwards regularly from quarter to quarter, because providers are going to be looking at their scores, are going to be seeing why they didn't meet the measure, and then plugging that hole and getting that measure met. Now, looking down here, here's another thing that's really interesting. Of those patients that did not have the measure met, we broke those out in more detail. And what's really fascinating is to look right here. This is patients that did not meet the measure. Of everyone that didn't meet the measure, almost 80% of them did have the visit from an eligible discipline done, but it was just not done within the required time window.
Yeah, it was within the 7 days, not the 3 days. Yeah.
So that is, that's something that's also very fixable. The visit's being done, it's just not being done within the window. And so, let's say, they're being done within 4 days instead of 3. Well, that's, a tweak that can be made, and you could really shift most of your ones that aren't met to being met just by making that a focus and being aware of those windows. So it's more of an issue of timing than an issue of what's actually being done.
Yeah.
Now, taking a look here, we just broke this out in a little more detail. So of all the patients that did have a visit in the last 3 days of life, this breakdown here shows you the percent of patients that had a visit for each of the disciplines. So a very high percentage of patients, as you would expect, that had a visit in the last 3 days had an RN visit. They also, more than half, had an aide visit, and about a quarter had a social worker visit. And then down 20% for chaplain, 13% for LPN, and very low number for your remaining disciplines. So that just kind of gives an idea of the distribution of those visits. And of course, those add up to more than 100% because some of them had both an aide visit and an RN and a chaplain. So we want to take a look now at the 7-day measure. And in looking at this, as you would expect, the score for this is a little bit lower because it has a little bit of a higher threshold to meet it. You've got to have 2 visits from a social worker, chaplain, LPN, or aide in the last 7 days of life in order to meet the measure. But again, it's a pretty high score, 76.1%. And this, again, is for our first 2 quarters of the measure, which are almost always going to be your lowest scoring quarters before people ever take a look at the scores and start working on improving them. Of that breakdown there, we see that 13.7% of overall patients had a visit from one of those disciplines, but they only had 1 visit. They didn't have 2, so they were very close to meeting the measure. They were just missing a visit from one of those disciplines. We can also see 9.6% had one or more visits from an RN, MD, MP, or PA only. They didn't have a visit from one of the qualifying disciplines there, and then a very, very small percentage there had no visits. So not having any visits is not a big issue. It's not something that we're seeing very commonly out there. However, not enough in the last 7 days or from the wrong disciplines are the primary reasons. Now, just to add a little bit of color to it, we also are able to take and calculate, based on that visit data, service intensity add-on eligibility. And so saying basically, did the patient have an RN or social worker visit in the last 7 days of life, and a little under 80% were eligible for that measure. So that just kind of gives you a different look at the data for that service intensity add-on. Again, just like we did with visits in the last 3 days, this is percentage of patients that had a visit in the last 7 days, the distribution of visits there. RN, you're seeing a similar, even higher number. Of course, you've got a bigger window there. Yep. So it's not surprising to see higher numbers. So almost every patient had an RN visit in the last 7 days of life. That's not shocking, but interesting to see. AIDS, 3/4 of patients had an aide visit in the last 7 days, and about half had a social worker, and about a third had a chaplain visit. So just kind of shows the services and disciplines that are getting patient visits done in the last 7 days of life. So this is just an interesting look at some very early data from that measure, and kind of hopefully helps you at your hospice to kind of know how your scores compare, and and get a little window into where other providers are either doing really well or maybe struggling with some of these measures. So I'm now going to hand the reins back over to Chris, and he's going to talk to us about the future.
Well, yeah, I've got a crystal ball, but what I really want to do is talk a little bit about, where is HQRP going? And, we already stated what you've known. There is that new composite measure. That's clear. That's going to be publicly reported in the near future. The new measure pair set hospice visits is coming. But one of the things that CMS states is they really want to have this program promote person-centered care. So how do we do that? What does that really mean? So I think that's going to be part of the evolution of how they think about it. They also want to make sure that it is, with stakeholder input. That's important. But the last bullet here is something that I think is going to really tell a story about how they're going to do it, is they really want a standardized and uniform manner or an instrument that we'll use to collect that data. So Zeb, you talked a little bit about the HIS measures. Many of them were very high and topped out, but I just actually looked at the data from that Q3 2017 composite scores, and when you look at the distribution here, again against our hospice profile, you see that the 50th percentile, which is that average or the middle, let me say it again, is the middle, is 95.4%. So that's where I come up with the slide title. When is a 95 not an A? So to your point, how do you differentiate between providers and hospices that have such high scores?
And when you think about that, if we just think of it purely in terms of stars, you're like at a 2.5 or a 3-star with that rank, which nobody really wants. So everyone wants to be a 4 or a 5, and so it is really going to be interesting to see how they rank and distribute that data.
So when we talk about the star ratings, this is used to help the public and referring partners differentiate between hospice agencies. But what is the difference? Boy, a 95 is pretty good. So the question that CMS has to address is, how do they come up with a star rating? Will they use clusters like they use for the HHCAHPS, the Home Health CAHPS program, or will they use some kind of percentile ranking with linear algorithms? So we see both of those out there today. So the public impact of stars was going to be pretty important in terms of both how they calculate it and then how you utilize that to improve your scores to make sure that you're top of the hospice group. Now, one of the things that we do see is star ratings are again, there's two different types, is the quality of patient care star ratings on the home care side, which uses the percentile ranking, and then the clusters for the HHCAHPS. But if you think about value-based purchasing, they actually roll the two together. So their overall score is actually the summary of both CAHPS and outcomes. So the question will be, will they do something like that to roll it in? They haven't announced that, but that's something that we'll have to keep an eye on. So when we think about, where is quality going, CMS in the 2018 rule did have some discussion about what they were considering for future years. Nothing that they proposed, but two of the areas that they were considering were potentially avoidable hospice care transitions. So this is areas when we talk about patients who were discharged alive is one of the types that they're concerned about, as well as access to levels of hospice care, like continuous home care and respite. Are patients getting the level of care that they are entitled to? So I think this really sets the tone for where quality reporting is going to go. I had an opportunity with Danielle Parati from Elevating Home. We talked a little bit about this in an earlier presentation about what is hospice quality. What is a good death? How are you meeting the palliative, social, economic, spiritual needs of a patient? And how are you meeting the patient's goals? A live discharge, is that good quality? Well, it's pretty clear that CMS is looking at that as part of a Pepper report that kind of discourages that. And what about death in 3 days or 7 days or 20 days? When is it that you are providing the level of care and the level of service that hospice patients should be provided, and what's the impact on providers, and how do you measure if the patient's goals are met? What would you think could be in a new assessment that would help to identify how successful you are in meeting those goals? And where does palliative care versus hospice fit in terms of pain, meeting pain needs of a patient maybe before they come onto hospice, or looking at care across settings? Does that change what quality is if they're in a skilled nursing facility, if they're in a hospice house versus in their own home? Are there differences that we need to understand and think about? And then finally, the app study that they did around hospice services talked a lot about visits, and we see that with the measure pair, the new measure pair, but is visits a measurement of quality? So kind of getting ready to wrap up here, the CMS has talked about this new assessment tool, which is now labeled the HEART tool for Hospice Evaluation Assessment Reporting. And so the questions will become, is abstracting versus assessment better? And what form should that impact the overall value in terms of what the questions are asked, and what items should be in there? Again, how do we identify what is the patient's goals in terms of that in terms of the questions of the assessment? And finally, a couple things about whose assessment is it? Hospice is interdisciplinary, so is it the team assessment or that's completing it, or is it based on the primary caregiver or clinician in that case? And we've already talked about this. Can everyone be excellent in that way as we think about overall quality? So in the final two slides here, in the 2018 final rule, they did beg the question about quality, and these are some of the bullets that they identified as things that they're going to be looking at. Again, this congruence of place of death and patient wishes, spiritual well-being, volunteer services, interestingly, cost of care as a question about quality. So some of these things are going to be addressed as they consider that new assessment. So finally, public reporting, August 2017, it began. We have Hospice Compare. And we've talked a little bit about things that we heard and learned from home care who's been through this before. What else can we learn from them in terms of the direction that these quality reportings would be going? What we would suggest, identify today where your opportunities for quality improvement in both your HIS scores and CAHPS hospice scores, address them now. They're either publicly reported today or will be, and the faster and the sooner that you're able to address and improve your scores, the better off you will be, especially as they start contemplating the star rating system. Understand, especially CAHPS, from a caregiver's perspective, that's important, and closely monitor and develop best practices. Look at your data by team, by case manager. Are you seeing that there's some that are better than others, and can you kind of identify those as a way to provide that through the rest of your organization? And be prepared for public impact. That's going to be an issue that you're going to have to face now as well as in the future, especially with star ratings. And then finally, what do you want measured? We have the ability through the regulatory process to provide commentary. So think about what is important to your patients as they develop quality performance and improvement into the future. So that's essentially the presentation we wanted to give to you today. I think we will have some time for questions. Rob, may I turn it over to you for a moment, and any thoughts from you?
No, this is great information. We've got we do have some questions that were submitted, and I don't know, and they're just some general questions, and I'm not sure if you can see the questions pane from your side or not. But rolling back to the CAHPS survey, someone made the comment that they're not getting a lot of surveys returned. Is that consistent? Is that what we're seeing in the industry?
So CAHPS Hospice actually has a higher return rate than HH CAHPS, interestingly. HH CAHPS tends to be in the low 30s, and CAHPS Hospice is in the high 30s, sometimes as high as 40. And so if there's a low number of surveys being returned, you know, it's good to check, make sure address, you know, that you're not getting bounces on your surveys, that the addresses are correct, that your caregiver address information is good, and that also, you know, you're doing, you know, whatever you can within the bounds of the protocols and guidelines to prepare caregivers for the fact that they will be receiving a survey. And you know, the thing that's different with CAHPS Hospice that's kind of nice, they will unless you're a really big hospice where you don't have to survey all your patients, if you're a small to medium-sized hospice, almost all of your caregivers are going to get a survey. So you can be pretty sure they're going to receive one. So, you know, it's if you're getting a low return rate, if you're getting, you know, below 35%, I would say that's not reflective of what we see typically in the industry.
Okay, and someone had a follow-up question to that. Is there any information regarding response rate if the CAHPS is done via phone or mail?
There is, I believe RAND may actually have some numbers on that available. I don't have them off the top of my head what the phone rates are because we're a mail-only vendor. But I believe there are some publicly available numbers for that.
Okay. Of course, we're getting questions about the recording, and of course, for those of you who joined us late, we are recording the presentation today, and we will send you out a link to that. Typically within 2 days. It may be Monday since it's Thursday today, but we will get this out to you. I think what we can do, there's some questions related to vendors directly, and we can address those offline. Some other survey. I think surveys seem to be a pain point. I'm just seeing a lot of questions around surveys about, and it seems to me that the rate of return seems to be a common theme around surveys being sent out in languages other than English. Someone also makes the point that if the survey says no, they don't want their name, then they don't get the survey at all. But that's what seems to be a general theme around the CAHPS information. And I think you addressed it as far as we could there, but it's just an interesting theme, I think, in terms of the rate of return. You mentioned it's higher than HH CAHPS.
I think I would also mention, Robert, it's also one of the more challenging sample files to pull together because you not only have patient information, but you've got caregiver mail information that has to be correct. And the way that RAND or CMS has RAND calculate the return rate, if you have patients that don't supply complete caregiver information and you're not even able to mail a survey, those count against your return rate. They still bring your return rate down, even if you don't mail a survey. So there are some unique things there, but even with that in mind, it still has a significantly higher return rate on average than HH CAHPS.
Okay. Well, we're at the top of the hour, so I'm going to stop the webinar recording now, and thank everyone for joining us today.